So looking at the Dutch data, Mads has reviewed this already, but just in brief, 2,000 benign Phyllodes. What is really important with this data is that they have a national data bank, which means if you had your first cancer in Miami and you moved to Chicago and then you recurred there, we can link you in the Netherlands. Margins are like the hottest topic, and I have reviewed probably 100 papers, and I've put up about 20 of them here. Tons of papers show that positive margins matter. There's a small subset that says, nope, actually they don't matter, and it's all bad data. It's all bad, including ours. And the limitations are they're mostly retrospective. Globally, they're pretty small. Even the largest one in the literature, minus the Dutch data, is like 500 patients, which means you maybe have 50 events, which means if you can do a multivariate, you have to put your recurrences together, so they're combining the analyses, and you can only put 3 or 4 factors into that analysis. So it's just bad data. So looking at the Dutch data, Mads has reviewed this already, but just in brief, 2,000 benign Phyllodes. What is really important with this data is that they have a national data bank, which means if you had your first cancer in Miami and you moved to Chicago and then you recurred there, we can link you in the Netherlands. And so they found that positive margins in this benign series really did matter. And on their multivariate, which was appropriate, they had a 2.5-fold increase in local recurrence with positive margin. Now, with that being said, that positive margin local recurrence is still just 9%. So they, and it sounds like the UK and the US all agree that if you resect a benign Phyllodes and you have a positive margin, you don't have to go back because you have less than 10% chance of local recurrence. Flipping to Malignant, so this is that series that was 500 malignant Phyllodes. They had surgery alone, so this is sort of a natural history study, which is nice. You can see they divided their data based on those that got breast conservation or lumpectomy alone versus mastectomy, 20% local recurrence for lumpectomy, 10% for mastectomy. And then they divided it out by tumor size. And what the conclusion there is, and roughly how we treat folks at Duke, is basically if you have a lumpectomy, you need to have radiation as a part of that care if you're malignant. And then if you have a mastectomy to a wide negative margin, but you're over 10 centimeters, we're going to consider adjuvant radiation in that setting as well. This paper actually linked local control to overall survival with a 2.5-fold increase in 2.5-fold worse overall survival when you had a local recurrence. This is the French sarcoma group. This is about 200 malignant Phyllodes patients. Just looking at the bottom left, you can see the blue line at the bottom is breast conservation with no radiation, and you can see that's really unacceptable local recurrence rates, so we should not be offering that to patients at all. In their multivariate analysis, they found that mastectomy was the only factor associated with local recurrence-free survival, so mastectomy is definitively better at preventing local recurrence than breast conservation. And notably, they concluded that local recurrence was not associated with overall survival. However, the numbers are relatively small, and those curves are pretty close to being significant with a p-value of 0.05. So you can take that as you wish. I think this is the very last slide. So this is the Dutch data again. So I know Mads went over it, but what's notable about this paper is that in their multivariate analysis, and they had almost 500 cases of malignant Phyllodes, so by far the biggest series with great follow-up data, they found malignant versus borderline has higher local recurrence, positive margin they found to be associated with local recurrence, breast conservation, so that matched the prior data, and of course tumor size. And they found no difference, interestingly, in a 0 to 1 millimeter margin as compared to a greater than 1 millimeter margin, and similar to the paper before, which feels a little incongruent with this very certain finding that mastectomy has lower local recurrence. And I grapple with that a little bit. This paper, their tumor size, so Mads, you had made a comment that their epidemiologic data, their distant disease is so much lower, and I think it's because their median tumor size is much smaller than on average. So that's probably the great healthcare in the Netherlands. They get to care quicker, they probably get to surgery faster, and so tumor size is smaller at the time of resection. And I'll stop there.